Describe me what you see in this video.
In the video, I can see a 8 weeks old child, non-dysmorphic, and he is in home settings, active with noisy respiration, uh, and noisy respiration. There is no devices attached, and he seems to be grown appropriate to his age. So, considering all things, this noisy respiration probably due to laryngomalacia.
Or neonatal stridor. Okay. So what are the differential diagnosis?
Yes, differential diagnosis may be vocal cord paralysis, hypocalcemia, subglottic stenosis, vascular ring, subglottic hemangioma, laryngeal papilloma.
Laryngomalacia age range, can you tell me?
Yes, laryngomalacia can start from the birth, and usually it resolves within 15 to 18 months of age.
Yeah, worsen in the first 2 months and then resolve 2 years. 2 month, 2 year. Easy to remember. So it is a laryngomalacia. It is not a hospital admitted, not it is a benign condition. It goes. So the differential diagnosis we are keeping: laryngomalacia, vocal cord paralysis, subglottic stenosis, subglottic hemangioma, laryngeal wave, tracheomalacia, peritonsillar abscess, laryngeal papillomatosis, vascular ring, and hypocalcemia. What history we like to ask in this patient?
Yes, onset, course, and duration, increasing factor and decreasing factor. And is it related to any posture change or feeding or sleeping? And the feeding, yes, any feeding, any if it's related to any kind of feeding for the reflux, and any vascular ring is any vascular lesion on the skin is present or not. And the perinatal history is important, especially any NICU admission, any ventilation needed or not, and history of hypocalcemia in mother or dark skin of mom.
Yes. A history as usual, onset, course, and durations increase and decrease. So onset we know that easily the first 2 months, our child also 8 weeks. Course is increase in the first 6 months, then gradually disappear. Duration of the illness increased by laryngomalacia is increased by supine positions, feeding, crying, and upper respiratory tract infections. Decrease in prone positions. Fever, weight, activity, sleep. That is common. We ask associated any vascular lesions for hemangioma. We are asking feeding like choking, reflux, and vomiting. Perinatal history regarding gestational age, prematurity, natal history of ventilation and intubation, previous history of calcemia, hypocalcemia, or dark skin mother. So we are when 3 or 4 differential diagnosis we keep with just targeting this history, then it easily come. Examination, what we do?
On examination, the vital sign, anthropometry, ENT examination, and also on skin survey, any vascular hemangioma is present or not, and chest examination.
Yes. So as well as all examination we do the airway, breathing, circulations, the vitals, hydration status, oxygen saturation, any respiratory cause, oxygen saturation, chest examination, ENT examinations, proton centers, and search for hemangioma. And what investigation we do?
Yes, flexible laryngoscopy. It is the confirmatory diagnosis. We can see their omega-shaped epiglottis, and fiber optic laryngoscopic may be done. We can measure the serum calcium level and transesophageal echo for any vascular ring present or not.
Yeah, fiber optic laryngoscopy after ENT consultations. Flexible bronchoscopy, omega-shaped epiglottis. It is flexible laryngoscopy or bronchoscopy. It is a bronchoscopy. Sleep study, we can do that if we suspect obstructive sleep apnea. Barium swallow for vascular ring. Serum calcium as hypocalcemia we keep, and transesophageal echo for vascular ring. Normally, no investigation needed, na?
But it
So,
may
what
be
is
a
the
tracheoesophageal fistula and gastroesophageal reflex. If we suspect that or see any other abnormality in the interior of the lungs, so we can do the fiber optic laryngoscopy after the consultation of the ENT.
yes? What is the indication of bronchoscopy in laryngomalacia patient?
Yes, bronchoscopy is to see the severity and other uh, abnormality and
Yeah.
other conditions such as it is may be associated with tracheoesophageal fistula, gastroesophageal reflux disease. For this reason, we might need fiber optic laryngoscopic. Otherwise, flexible bronchoscopy is this the confirmatory diagnosis.
So indications of bronchoscopy are shortness of breath, dyspnea, choking, apnea, or cyanosis. If diagnosis is uncertainty, parental concern, and persistent more than 18 months. What management we offer if it is laryngomalacia?
Yes, if it is, we can go through its multidisciplinary approach, and it usually in case of mild, when the weight gain is normal, so we can reassurance of the spontaneous resolution within 15 to 18 months. If it is there is concern regarding the growth and difficulty in the feeding, cyanosis, so we can refer the patient to otolaryngologist. And medical treatment is suppression, speech and swallow therapy by the salt and high calorie diet.
Where you get this? Management of laryngomalacia is reassurance that it will improve after 18 months. If severe and heavy reflux, then we give the antacid and reflux medications. If apnea, then evaluate the sleep study up to tracheostomy. And we exclude the red flags. The red flags are like poor feeding, not thriving well, distress affects the sleep and persisted more than 18 months. The multidisciplinary team, I will involve my consultant pediatrician, ENT, gastroenterologist, and anesthesia. So this is all about these video stations. Okay, we are moving